Hello everyone, hope you're all doing good. In this video, we are going to discuss about endometriosis. See, endometriosis is an estrogen dependent inflammatory gynecological disease. Okay. So, this is an estrogen dependent as well as inflammatory gynecological disease, and there is presence of functioning endometrium. The endometrium includes both glands and stroma, and this will be present in other sites than the uterus. Okay, so that is called as endometriosis, right? Now, this is not a malignant condition, this is actually a benign condition only, but it is locally invasive and also it can metastasize. Okay. So, this condition affects approximately 10% of the women of reproductive age, but only 3% of them will be having symptoms. Clear? I hope you understood this, right? Now, let's see what are the risk factors for developing endometriosis. So, risk factors for developing endometriosis. So, first one, the risk is more when she is a nulliparous woman or she had early menarche, late menopause, there is heavy menstrual bleeding, when she has Mullerian anomalies or outflow tract obstruction, when she consumes high amount of unsaturated fat, there is exposure to diethyl stilbestor in utero, and if she has a family history of endometriosis. Okay, so these are all the causes that can lead to endometriosis in a woman. If she is an nulliparous, she has an early menarche and late menopause, there is a heavy menstrual bleeding. Mullerian anomalies are there which will include your outflow tract obstruction. There is increased consumption of unsaturated fat, there is exposure to diethyl stilbestrol in utero, and finally when there is a family history, right? Yes. Now, let's discuss about the pathogenesis of endometriosis. So, pathogenesis of endometriosis, actually this is a unclear one, but there are so many theories given to describe how endometriosis happen. Okay. So, first theory is Sampson's theory of retrograde menstruation. According to this theory, there is retrograde flow of the menstrual blood through the uterine tubes during menstruation. Okay. So, the endometrial fragments will get imposed on the peritoneal surfaces of the organ also, And another point is, this is one important concept which will give you an idea about how pelvic endometriosis is going to happen. Clear? And the second theory is coelomic metaplasia theory, that is given by Mayer and Ivanov. Okay. So, according to this theory, there is chronic irritation of the pelvic peritoneum that is caused by the menstrual blood, and this will be causing colonic metaplasia, which will be resulting in endometriosis. Clear? Now, this concept is going to explain to you about the endometriosis that is occurring on the abdominal viscera, rectovaginal septum and the umbilicus. Clear? Yes. And the third point is about the Halban's theory. This is a lymphatic theory. Okay. So, here it says that there is possibility of the normal endometrium to metastasis to the pelvic lymph nodes through the lymphatic drainage of the uterus. Okay, through the lymphatic drainage of the uterus. Clear? Right. There is also another theory which is known as the vascular theory. Now, there is vascular dissemination of the endometrium, which will be leading to deposits of the endometrial tissue in various distant organs like the lungs, even the arms, thighs, etc. Okay. Another final theory is about the direct implantation theory. Here, it says that endometrial or decidual tissues start to grow in susceptible individuals when implanted at a new site. Okay. So, these are the 5 theories about endometriosis. One is Sampson's theory of retrograde menstruation, another one is coelomic metaplasia theory, and next one is Halban's theory. Sorry, this is coelomic metaplasia. Okay, so this is coelomic metaplasia theory, then Halban's theory, vascular theory and direct implantation theory. Clear? Right. Now, let's see about the genetic and immunological factors that will be leading to endometriosis. Okay. So, genetic and immunologic factors. Okay. So, endometriosis also has an autoimmune basis. You have to understand this. Okay. And this autoimmunity is affected in both humoral as well as cell mediated immunity. Okay. So, because of this, there is release of various cytokines and growth factors as well. If you see the peritoneal fluid of these women, the peritoneal fluid will have larger macrophages that will secrete multiple growth factors and cytokines. So, the peritoneal activity in them is increased in the presence of interleukins and growth factors. There is also high level of local estradiol as well as prostaglandin E2 in them, and the tissue resistance to progesterone is seen. Okay, there is tissue resistance to progesterone. Clear? Right. Now, let's discuss about the pathology. So, pathology of endometriosis. I have already told you it is nothing but the endometrium at an abnormal or ectopic sites. The endometrium will include both glands and stroma. Okay, and in this endometrium you will see more of proliferative changes when compared to the secretory changes, and because it is an endometrium, there is response of this endometrium to the cyclical hormones as well. So, there is cyclical growth and shedding of the endometrium also till menopause. Okay. So, the shed blood will be encysted and it may become tense and grow for rupture as well. Clear? And finally, you should know the blood that is present here is an irritant. So, it can cause a dense tissue reaction that will result in fibrosis or adhesions or puckering of peritoneum. Okay. And next point is, if you have deeper lesions of endometriosis which are more than or equal to 5 millimeter and they are progressive, what happens? Yes, if there is a cyclic bleeding, the cyst is going to enlarge. At the same time, the serum will be absorbed. That time, the content will be mostly like a chocolate colored one. Okay, mostly looks like a chocolate colored content. Okay, so this is usually seen in the ovary, that is known as, yes, very chocolate cyst. Okay, the serum will be absorbed and only the RBCs and other materials that is present in the blood will be retained. So, that will be appearing as a chocolate cyst. Clear? And the next point is about the macroscopic appearance of endometriosis. If you see endometriosis, the early lesions may look vesicular and sometimes powder burns lesions can also be present, which are nothing but they will look like small black dots that are deposited in the uterosacral ligaments and the pouch of Douglas. Okay. Next point is, already we have seen there can be fibrosis, scarring or puckering of the peritoneum, and other appearances you can have will include a red flame shaped appearance or a red polypoidal appearance yellow brown patches, white peritoneal areas, circular peritoneal defects, and subovarian adhesions as well. Okay. So, let us see some of the presentations of endometriosis. So, these are superficial peritoneal endometriosis which is not visible on imaging even, but while during laparoscopy you are able to see this black colored dots, right? And ovarian endometrioma or a chocolate cyst usually appears like this, a dark hypoechoic area in transvaginal ultrasonography, and on laparoscopy this will be enlarged, okay? And a deep endometriosis of sigmoid colon is seen here, okay? You are able to see the vascularity that is seen in the sigmoid colon, and yeah, you are able to mention some polypoidal red flame shaped areas in the sigmoid colon, okay? So, these are flame shaped areas that are seen, okay? And this is a circular peritoneal defect that is created by endometriosis, okay? You are able to see some red color lesions also here, okay? So, endometriosis has variable presentation that you should understand, right? And now let us talk about the microscopic appearance of endometriosis. Microscopic appearance means here we will be able to see both glands and stroma. The lining epithelium can be seen with flattened cuboidal cells, and later it can be replaced by granulation tissue as well. And adjacent to this you will be able to see several polyhedral phagocytic cells that will be laden with blood pigment hemosiderin. Okay, so this is how a microscopic picture of endometriosis will be there. You will be able to see both the glands and stroma of the endometrium. That point should be clear, right? So, let us see the microscopic appearance now. So, this is a microscopic picture where you are able to see the endometrial stroma as well as the endometrial glands as well, right? Now, let us see the clinical features with which these patients can present, okay? So, the clinical features of endometriosis, usually the age group of these people will be between 30 to 45 years, and most of them are nulliparous and infertile as well. Some will have family history of endometriosis, and they can have outflow tract obstruction as well, okay? So, let us discuss about the symptoms now. So, symptoms of endometriosis will mostly depends upon how much depth the endometriosis has gone than the size of endometriosis, okay? It is more dependent upon the depth than the size or extent, okay? So, when the depth is more than 5 millimeter, it can lead to symptoms like dysmenorrhea, which can be a secondary dysmenorrhea. Usually, dysmenorrhea and endometriosis will be starting prior to menstruation. It takes place during menstruation and may take time for cessation even after menstruation, okay? So, during all the 3 periods the dysmenorrhea is seen. So, dysmenorrhea in endometriosis is also named as triple dysmenorrhea, okay? It can also give rise to abnormal uterine bleeding. Okay, there can be menorrhagia, or sometimes it can even present with premenstrual spotting. And next presentation, there can be infertility. About 30 to 45% of the patients with infertility present with endometriosis, and some may even complain to you about dyspareunia, especially when the lesions are present deeply in the pouch of Douglas. Okay. Some women may also present to you with chronic pelvic pain, and that will produce pelvic discomfort, lower abdominal pain, and even backache. Clear? Yes. Now let's see what are the causes of pain. Okay. So causes of pain. Pain is caused mainly due to platelet-derived growth factors, cytokines. There can be nerve irritation when a deep penetration of the lesions are happening, or there is also pain with endometrioma formation. There can be local inflammatory reaction also. Tissue necrosis can also happen, and there can also be adhesion formation. Okay. Now, apart from this, there can be other associated symptoms, like she can present with urinary frequency. Okay, that can result in dysuria, hematuria, or even hydronephrosis. Okay, when the lesions are involving sigmoid colon or the rectum, there can be dyschezia, diarrhea, constipation, and even it can present as melena. Okay, and we have seen the blood is going to loss in all the sites. Okay, wherever endometrial gland is present, the bleeding is going to happen. If the bleeding is going to happen anywhere inside or outside, what is going to happen? Yes, definitely the patient will be getting anemia, that will be presenting to you as chronic fatigue, and there can be hemoptysis or pleuritic chest pain also when the lesions go and involve the lungs. And finally, if the lesions are present in the surgical scars, okay, the scars can also go for cyclical pain as well as bleeding. Clear? Right. Now, on examination of the abdomen, usually you will see no abnormality, or you can see a mass that is arising from the pelvis. There can be an enlarged chocolate cyst that will be presenting to you as an abdominal mass. There can be formation of tubo-ovarian mass, and the mass can be tender as well as with restricted mobility as well. Clear? Now, when you do a pelvic examination, you will be able to see the woman will have tenderness, and nodules will be felt in the pouch of Douglas, and nodular field can also be seen in the uterosacral ligaments, and there will be fixation or retroversion of the uterus as well. Clear? Yes. When you do a perspeculum examination, you will be able to see bluish spots on the posterior fornix. Clear? Right. Now let's discuss about the investigations. So investigations, we can do serum markers, okay, and the most important serum marker that is associated with endometriosis is CA125. But remember, the CA125 is not specific for endometriosis and there will be only a moderate elevation. Okay. However, this can be helpful in assessing how the endometriosis is going to respond to you for your treatment. So, for therapeutic assessment, we can use this marker. There is another marker called MCP1, okay, that is monocyte chemotactic protein 1, which will be increased in peritoneal fluid. Glycodelin, that is a placental protein, will also be elevated. And finally, the inflammatory markers like interleukin 1 and interferon gamma will also be elevated. Okay. Let's see about the imaging in endometriosis. In ultrasonogram, especially on TVS, that is transvaginal ultrasonogram, you can get details about endometriomas, and this can be combined with endorectal ultrasound as well to rule out rectosigmoid endometriosis. Okay. So, usually the appearance in endometriosis will be nodule-like, and this can be single or multifocal. Okay. And usually endometriosis is going to appear as a hypoechoic nodule in an ultrasonogram. Clear? Now, when you compare CT usage, CT is better when compared to ultrasonogram for detection of endometriosis. However, a need for MRI can also be there because MRI is a best diagnostic tool for endometriosis, and they will appear hyperintense with a T1 weighted images and hypointense in a T2 weighted images. Okay. And this is also better to diagnose deep endometriosis. Okay. Deep endometriosis means about the deeply going lesions. Okay. Depth of the lesions can also be made perfectly with an MRI. Clear? Right. Now, however, apart from these investigations, the laparoscopy investigation is considered the gold standard investigation for endometriosis, because with this you can assess the site, size and extent of the lesions. You can do a biopsy as well if you are needing. Staging of endometriosis can be done simultaneously. I will be explaining about it shortly. Then simultaneously we can remove the lesions, that is the treatment can also be done. So these are the advantages of doing laparoscopy in a woman with endometriosis, and hence laparoscopy is considered the gold standard investigation for endometriosis. Clear? Right. And finally, apart from this, you can even offer them intravenous ureterography, because there can be, if you have any suspected ureteric involvement, at that time you can even give them IVU, right? Yes. Now let's see about the differential diagnosis of this condition. So differential diagnosis of endometriosis is based upon the symptoms. Okay, suppose if she is presenting with endometrioma, okay, if she has an endometrioma, that is nothing but a chocolate cyst or endometriosis in the ovary, then you have to know, you have to differentiate it from the benign or malignant ovarian cyst, and then also the hydrosalpinx. Okay. Suppose if she is presenting with chronic pelvic pain, especially of the lower abdomen, you have to keep in mind the causes like irritable bowel syndrome or any causes that will be leading to pelvic vascular congestion. Okay. And remember, dysgeusia can also be a presentation where you will keep, yes, very good, anal fissures as a differential diagnosis. When they present with the dysmenorrhea, you will keep, very good, adenomyosis or else a leiomyoma as differential diagnosis. Sometimes they can even present with dyspareunia alone. So that case you have to keep your vulvodynia, psychosexual problems, as well as infections like vaginitis or cervicitis as differential diagnosis, and then dysuria should be ruled out from UTI. The presentation of infertility is also possible, where you have to rule out other causes of infertility like luteal phase defect, the other causes of anovulation, etc. Clear? So this much differential diagnosis for endometriosis is there, right? Now let us see what are the complications that a woman will develop with endometriosis. So complications, first one, she can go for endocrinopathy, okay, and this endocrinopathy will be one of the cause for infertility. And second one, there can be an endometrioma formation, as I told, that can go for rupture, or even an infection can also happen in an endometrioma. And finally, there can be obstruction. Obstruction can be intestinal and even ureteral obstruction can also happen, that will result in hydroureteronephrosis. Okay. However, you have to remember one more fact, that the risk of ovarian malignancy is increased in a case of endometrioma as well. Clear? So these are the complications. First one, it can lead to infertility. Next one, an endometrioma can go for rupture and infection, as well as it can also lead to increased chances of ovarian malignancy, and obstruction can happen at the level of intestinal or ureteral. That means it will lead to hydroureteronephrosis. Clear? Right. Now let's see about the staging of endometriosis. Okay. So this is the stage, and let's see how the condition will be presenting to you. Okay. So stage 1 is where there is minimal endometriosis and you have only few superficial implants. Okay, and stage 2 is a mild endometriosis where you have more deeper implants. Okay, stage 3 is where you will have moderate endometriosis. You will have many deep implants. There can be cyst on ovaries, either on one ovary or two ovaries. There can be presence of filmy adhesions as well. Okay, and finally it's stage 4 where the endometriosis is severe. You have many deep implants and there are large cysts, okay, that is present on one or both ovaries and many dense adhesions. Okay, so there is a scoring system for the endometriosis. I think that is quite vast for you people. So you just know what are the stages. Okay, so this is minimal endometriosis. Okay, so stage 1 is minimal endometriosis, mild endometriosis, stage 3 is moderate endometriosis, and stage 4 is severe endometriosis. Okay, I can add one more point, like the points given to each stage. Okay, stage 1 will be where it carries 1 to 5 points. Stage 2 means it will be between 6 to 15 points, and stage 3 carries 16 to 40 points, and if it comes more than 40 points, it will be considered as stage 4. Clear? So this is all about staging of endometriosis. Now, the severity score, however, does not correlate with the level of pain she is having. Clear? Right. Now, what are the limitations you will have with the scoring system? Anyhow, laparoscopy or laparotomy must be done. There can be inter-observer or an intra-observer variation. Third one, it is not correlated with the fertility outcome or mode of treatment that can be given. Clear? Right. Now let's see about the management of endometriosis. The options for management of endometriosis will include: number 1, you can give an expectant management where only you are going to observe. Second one, you can give medical treatment with hormones. You can even offer surgery which can be conservative also. Then you can give both medical as well as surgical treatment. Clear? Now let's see about the expectant management. So expectant management. When you will try expectant management? When the female is unmarried and she is an young woman who is planning her pregnancy, she is of the menopausal age group and there is minimal endometriosis. Okay. So in this group of women, how will you do expectant management? For expectant management, you are going to give them analgesics, especially NSAIDs or prostaglandin synthetase inhibitors. Okay, so that will help in reduction of pain. And then specifically the drugs like ibuprofen 800 to 1200 milligram. Other option is giving mefenamic acid. Okay, and Unmarried women are usually advised to get conceived because pregnancy improves the condition of endometriosis because there is only progesterone action, estrogen action is less during pregnancy, right? Yes. Next one is medical treatment. We'll be usually giving hormones and you have to remember this is an estrogen dependent disease, okay. So, with hormones, the atrophy of the endometric implants can be seen and other medications can also be advised, okay. And finally, surgical management. So, when will you offer them surgical management? So, the indications of doing surgery in a female with endometriosis means there is severe symptoms in the woman, that is especially unresponsive to hormone therapy. There is deep infiltrating endometriosis. There are pelvic adhesions when there is severe endometriosis, and finally when the endometriosis is more than 1 centimeter. Clear? Right. Now let's see what are the conservative options of surgical management we can have. Okay, first one is, yes, we can offer her a laparoscopy. Okay, in laparoscopy we can go for cauterization of the lesion or a laser vaporization. Luna, that means laparoscopic ultrasound, nerve ablation, because we have seen nerve irritation is one of the cause in endometriosis, and hence this is offered when the pain is much severe. You can even offer adhesiolysis, excision of the rectovaginal endometric nodules can also be done, and with this procedures there will be improvement in the infertility problems in the women. Okay, you can go for cauterization, laser vaporization, Luna, that is laparoscopic ultrasound, nerve ablation, adhesiolysis, rectovaginal nodules, and you can increase the fertility as well. Clear? Right. Now, let's speak about endometrioma. So, endometrioma, when the size is less than 3 centimeter, you can do a laparoscopic aspiration. Okay, and the cyst wall can be destroyed by a laser vaporization. Okay, suppose if the size is more than or equal to 4 centimeter, then again you have to go for an ovarian cyst drainage, and suppose if there are adhesions, you have to go for adhesiolysis. Okay, and then you can also offer her a laparoscopic cystectomy. This laparoscopic cystectomy relieves pain and the fertility rates will be improved after cystectomy, and also you will be able to see high pregnancy rates within 6 months. However, destruction of ovarian cortex will also be there. So, the ovarian reserve will be reduced in these patients. That is one side of it. Clear? Right. Now, for definitive surgery, let's see the indications. when she has no prospect for fertility improvement, when the other modes of treatment have failed and the woman has completed her family. Okay. So, this can be done by laparoscopy or laparotomy. The permanent solution is hysterectomy with bilateral salpingo-oophorectomy. Okay, this will be improving symptoms in almost 91% of the cases and excision of the endometriotic lesions wherever it is found. Yes, that's it. Now, whenever you get an endometriosis case, okay, an endometriosis that is suspected based on pain or infertility, say suppose if she has pain, okay, you have to ask her what is the severity of her pain. Either it can be mild to moderate or it can be moderate to severe pain. Okay. When she has mild to moderate pain only, then you can consider empiric treatment by giving oral contraceptive pills or progestins. Okay. When she has moderate to severe pain, then you can proceed on with the laparoscopic diagnosis and that can be followed by surgical excision and ablation of the lesions. Okay. And this can be soon followed with immediate post-surgical therapy with danazole or oral contraceptive pills or GnRH agonists, progestins, etc. Okay. Whereas in some cases there can be recurrence as well. Okay. When the recurrence is there, you can give them medical therapy up to 6 to 9 months, and when there is intractable pain, okay, pain that is intractable, then childbearing is also not a factor. You can offer them total abdominal hysterectomy with bilateral salpingo-oophorectomy. Clear? So, this is how you proceed with pain management. Okay, when it is mild to moderate pain only, you can give empirical treatment. When it is moderate to severe pain, you have to go for a laparoscopic diagnosis or management. Then you have to go for surgical excision by adhesolysis of the lesions. Immediate post-op, you have to supplement them with post-surgical treatment like danazole, GnRH agonists, progestins, OCPs, etc. Suppose if there is recurrent, you can try medical therapy again for 6 to 9 months, or if she has completed family and the pain is intractable, you can offer her total abdominal hysterectomy with bilateral salpingo-oophorectomy. Clear? Right. Now, let's see what if she has an infertility. Okay. Infertility, there can be many causes. You have to do a concomitant workup for all the other causes as well, and sometimes you can offer her expectant management, and in some cases you will be following it with laparoscopic diagnosis, okay, the same surgical excision as well as ablation of the lesions, and this can be followed by in vitro fertilization with superovulation techniques. Clear? So this is all about endometriosis. So I hope you have known in detail now what is endometriosis, what are the various types of endometriosis, what are the staging, what are the clinical features, and we have also discussed about the management in detail. So with this, we'll be completing this video. Until we meet in the next video, keep going, happy learning, take care, bye bye.